Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, the founder and CEO of the Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're building a community of healthcare professionals committed to making scalable impact on global equity. Join me in insightful conversations with global health innovators as we explore the current and future state of healthcare. Be a part of the mission. Let's create lasting change together. Today, I'm so excited to be talking with Jenn Johnson. Jenn Johnson is a dedicated nurse with over 16 years of experience in my favorite place, the emergency room, doing so across Northern and Southern Ontario, Canada. A frontline worker through most of the challenging times, Jenn has witnessed firsthand the intense pressures of the profession, from life and death moments to the struggles of coping during the pandemic. A passionate advocate for nurse well-being, Jenn's new book, Nursing Intuition, was written to support her peers by offering insights on how to reconnect with the love of nursing and foster resilience in a rapidly changing healthcare environment. She is also the CEO of RX for Growth and a wife and mother of 2 children. It's my great pleasure to welcome you to the podcast, Jenn.
Thanks, Dr. Kim. So glad to be here.
I'm very excited to have this conversation with you. Before I start, I always offer our guests the opportunity to tell us if they have any affiliation disclaimers or to identify any conflicts of interest. Do you have any you want to bring forth?
The only conflict is that I'm still at the bedside and trying to do, both things. That's trying
More of an internal conflict than a conflict of interest.
Constant internal conflict.
I get that. I really get that. So I'm really excited to have this conversation with you today. The health and well-being of our healthcare professionals and the health or lack of health of our healthcare system is certainly a topic I love discussing with other individuals and finding out more about your perspective as you work in a whole different healthcare system, how things can be similar and different and have similar struggles. But before we get into all of that, I want to get to know you a little bit. So if you can tell us a little bit about your background and how you got into healthcare.
So I fell face first into healthcare. I originally went to Lakehead University for a biology degree, got maybe a year through it, got into organic chemistry and failed the first half of my organic chemistry course. And it was a year-long course. And so looking at it and going, this is not, I've never failed a course before. What am I doing? And thankfully, there was a girlfriend that I was in residence with in my first year who was in nursing school, and we'd go through her textbooks. I'm like, oh, this is so cool. All the gory pictures and everything. You're like, this is really interesting. So swapped into the 3-year compressed program, ended up meeting my now husband and started in rural medicine. So in a hospital in a town less than 5,000 people, where there was just one registered nurse for the emerge and one registered nurse with 2 registered practical nurses or LVNs on the floor. And the floor was about 14 beds, but no RT, no vent, no CT, no MRI, no nothing. Looking back, I don't think people realize just how many things could go wrong just simply because there was no access. But with that job, one day you're in emerge, the next day you're on the floor, and you kind of bounce back and forth. And so fell again face first into emergency nursing and very much fit my personality of undiagnosed ADHD.
Yeah, I don't know if we start out ADHD, but this line of work definitely creates that in the people that work in this line of work.
you get real comfortable with like 16 things going on, and you're like, oh yeah, where was that thing? And just a band-aid on the big issue and on to the next, and band-aid on the big issue and on to the next.
Yeah, I love what you say about rural healthcare. So I reflect on this often as I have matured and grown in wisdom as an ER doctor. It's another way of marketing age there. Is I have become much more of a critical access and rural health specialist and love that kind of work. But in addition to there being healthcare disparity across the globe, so 78% of all the physicians trained across the globe are working for 24% of the population in high income countries.
That's insane.
And what we're seeing, yeah. And so what we're seeing and what you're talking about here is not only is that happening on a global geographic scale, but even within that 24%, the US and Canada, those are both high income developed countries. There is also that disparity happening within communities. So rural healthcare and critical access healthcare is a different animal. And so many resources are concentrated into urban centers with the tertiary care hospital, with all the specialists and all the tests and all the things. And there's lots of patients with no access to the CT scan, the cardiologist, the ventilator, etc. And then there's a few brave souls that choose to be the interface between those two worlds. And very rarely do those brave souls get thanks or recognition. Often they get lack of understanding and pushback. I know during COVID, Jen, getting a patient from a hospital with no ventilator and no specialist and just an ER doc in the whole hospital transferred to another hospital, even to their ER, was impossible. And there's just a general lack of understanding of what is not possible at these places with different resources. Tell us a little bit about what that was like for you.
Yeah, it was looking back, I don't know if I would have been as comfortable as I was then if I had known what like tertiary healthcare looked like. You know, I've worked in a pediatric emerge, I've worked in a trauma center, a different stroke center, I've worked at all these big places now. Looking back, I'm like, oh my God. You know, if you were having stroke like symptoms, back in the day, it was, I think we only had a 2-hour window, and it was 2 hours driving from our hospital to the nearest hospital with a CT scan. So people just hoped that they were having a TIA because there was no way that you were going to make that window any way, shape, or form. Even, you know, there's so many things where it was just, yeah, somebody came in. So this little old lady, 2 out of 10, just reflux. Beautiful, lovely lady walked in just fine. No cardiac history. All of a sudden, oh no, huge STEMI. And we're going like, oh, okay, what do we do for this? Well, we're going to give her TNK. I've never given TNK before. And so you're calling down to the floor to be like, hey, I need help with this. There's so many warnings, and the pharmacy tech is all these warnings. So I'm like, okay, I have no idea what I'm doing. So the older nurse comes down and we do everything. Well, doesn't this patient, we've called out for critical, which is our ambulance transport system. So both air as well as land, but we were looking for air. And by the time air landed, this patient was, her color was going. All of a sudden, she's like, got a poop. And we're like, and my partner's going, oh my God, the death poop. And I'm like, what are you talking about, death poop? And she's like, oh no. She wants to get up. She wants to bear down, all these things. And do not let her up out of that stretcher. And trying to keep track of the, the reemergence rhythms and all these things. And doesn't she die just as orange lands and comes in? And so we run the code, and unfortunately things don't go well. We think she might have blown out her septal wall, but we never heard. It's small town. You weren't going to send out for an autopsy. She was 77. It's family docs covering the ER as ER docs. And they're just like, "Oh, that was actually my family patient, and yeah, I think we're good." And you're like, as the nurse, you're going, I missed something. I must have screwed up. Like, how did I mix the TNK wrong? Did I not do what I was supposed to do? Did I delay something, or was I too quick with something else? And those questions never got answered. Everybody was like, "Oh, well, okay," and then on to the next. And you're going, what just happened? It was one of the very first very critical patients that came into the ER, because thankfully rural medicine, if I think now 60% of what I see could be seen at walk-in clinic or in urgent care, probably 70 to 80% of what's coming into rural, they all the joke was people would drive around to see whose car was parked in the ER physician spot, because they all know who drove what car. So whoever, if you couldn't get in with your family doc who just happened to be working the ER that morning, oh, you just stop in and come in with your toe pain or UTI or whatever else. And, looking back, it's just like, oh, we could have gotten into so much trouble. Like, you know, start questioning, like, if we would have had a CT, would we've gotten more answers for this patient or that patient who died? And had we had RT, would I not had to have, begged a 25-year-old for 6 hours waiting for Orange to come in? And like, the physician at the time, unfortunately, was just like, oh, I've forgotten how to intubate. And I'm losing it, going like, "What are you talking about? Because I'm brand new. You can't be brand new too." So, like, call somebody else in. I don't care who you call somebody else in. So it's just, reflecting back, I'm like, I would have been crapping my pants 24/7, 365 with the knowledge I have now working up there, knowing that so many things are preventable, and having access to even just endoscopy alone, how many better outcomes we would have had, instead of waiting days to fly somebody out for a CT scan. It really does boggle my mind nowadays.
So there is no nowadays. Those days exist. They still exist. They
Oh
very much
god.
exist. So I know it feels like the
Oh,
past because that was your experience in the past,
yeah.
but that exists today. That exists
Ugh,
today in Canada, that exists today in America, that definitely exists across the globe. And it especially
yeah.
exists for people that are rural and in small communities. So, yeah, I mean, I work at a critical access hospital. We don't have, um, we have limited supplies of type O blood. It still takes 20 minutes to get it. So if you need to resuscitate somebody, we don't always have reversal agents. We sometimes don't even have the lab test to figure out if your INR is elevated. There's definitely a huge disparity between urban care and rural care. And we need to all talk about that and address that, right? Because that is part of the disparity that we are also perpetrating on an even larger scale across the globe, right? Lots of people get to have more and more care. Some people get to have more and more care, and even more people get to have less care.
Yeah. I think about that community now, and so my mother-in-law is still up in that community, and my husband's the entire family is still all up in that community, and they're getting up there, and one of these times she's either going to be too sick to go back or too sick to come down, and I personally hope that she's too sick to go back so that we can make sure that she's got the right access down here, and that's very selfish of me. But, you can't help but worry about what's going on, and knowing, the bullying that went up when I started up there, and I hope that it's changed, because there were so many nurses who were pushed out just because of one personality. Um, and it's unfortunate because they were already deemed an underserviced area. So just like, I hope they're doing better. I really do.
Yeah. And, how do we bring recognition so that those communities do get resources, right? And you can't do it by, for me, it means going there. It's bringing our services, our people there. so that it's visible, so that we can use our voices and platforms to make the needs visible and then to bring more care there. Because otherwise, things don't really change. And so it's trying to be the agent of change. Awesome. Well, thank you for all of that. Right? That's a heck of a journey.
No worries.
So your current passion is in nurse and healthcare burnout and nursing wellness.
Yep.
You've actually used the term survival
Oh, yeah.
to describe what you teach nursing students. What are you experiencing in healthcare now or in the recent past that brings you to that?
So, writing my book, I was invited to speak to some first year nursing students out at one of our universities. And I'm talking September first year, not even a full month in, and talking to them just about, intuition and my grief stories and how to cope and what to expect and a lot of these things. And all of their questions had me just flabbergasted. They were asking about, how do I prevent work or how do I prevent burnout? How do I manage work life balance? How do I grieve a patient? How do I not get, drawn into toxic relationships? And you're like, I don't think I've ever asked myself these questions in 16 plus years. Kudos to you guys for being on it from not even moment one and to be so aware of exactly what you're stepping into. Because from the nursing end, looking back, it felt like, oh, you guys you're going to save everybody and it's going to be great. And it's such a wonderful career. And you get out into the real world and you're like, whoa, this is a lot. And, coming to terms with not everybody will live and being able to provide a dignified death to others, needs that was totally skipped over when truly that's probably one of the most rewarding parts now for me. Um, and, the difference between what education was teaching and then what actually happens at the bedside were just so different when I graduated. And then throw in the bullying element and no support and all this kind of stuff. It was like, okay, like let's try to better prepare those coming into nursing and coming at to the bedside, that there is so many more skills that we need to not only just mention, but try and develop a little bit before we even get out of nursing school. Dealing with grief. How are you supposed to grieve somebody that you only knew for 20 minutes and they were dead the whole time? Like, how do you get to that point? How do you start saying no to things and not feeling guilty? Because, the stereotype that I feel like in nursing is you're not a good nurse unless you give everything of yourself and leave nothing for you. Otherwise, oh, you're selfish. Oh, what do you mean you're saying no to a shift when you know that they're short staffed? Well, I'm saying no because I'm not mentally, physically, or spiritually able to go in right now. And, I don't want to have to come up with some elaborate excuse as to why I'm not coming in. And the fact that they routinely use guilt to kind of, get you to come in is a horrible practice. And, we need to start really changing how we're looking at things and how, nursing, as much as nursing can be a calling for some, it's a career. It's a career that has many different paths and many different lengths and many different expectations. So if you're not meant to be at the bedside, if that's not what brings you joy, that's okay. You're still a nurse. If you're meant to go to be a nurse practitioner or get your doctorate or and do nursing research, you're still a nurse. Like these, just because you're not at the bedside doesn't mean that you're not a nurse. Do you have different skills? Absolutely. Do you have different knowledge? Absolutely. But we need to stop kind of dividing us as to like bedside, non-bedside, because we're all there for the right reasons. We're all there for the patient, and whether our strength is being at the bedside or being in public health and trying to ensure that everybody's got access to vaccines and this, that, and the other, everybody's got a niche that they've got to fill, and there are so many corners of nursing that there's enough room for everybody. So I don't understand necessarily why we want to kind of nitpick each other and kind of put each other down as like, oh well, you're not bedside. Like, oh, I'm better because I'm in the ER. Oh, I'm better because I'm in the ICU. Like, who cares? I couldn't do the ICU. That's not my bag. I couldn't do the OR. Cold and slow and way too type A. Absolutely not. There are people who can't do the ER. That is fine. That is why I'm there.
Yeah, the truth is you could do it. You just would rather not do it. You could.
I
Yes.
in
Yeah.
tight situations I have.
Yeah.
Did I enjoy it? No. But did it give me a better insight as to what they deal with on the day-to-day? Absolutely. And it's usually not until, people like to rag on the ER and, oh, this wasn't done, that wasn't done, blah, blah, blah. And it's like, come on down. Come work for a shift and see just how much chaos actually happens in a day, and see, how we do things versus how you do things, because your number one major issues are very much different from ours. A lot of ours are big Band-Aid, treat them and street them, or big Band-Aid off to the floor if there's a bed available.
Yeah. Yeah. I mean, I think more and more ERs are doing much more critical care now because boarding is such a big problem. And it has been since COVID. Look at that. It's so easy for the time to fly by here. I do want to touch a little bit on COVID
Yeah.
and what happened during the pandemic. What would you say COVID-19 brought for you as a nurse and to this mission you have now?
Fear that I've never dealt with before, fear that I've never even thought about things before. You don't think about going to work and then you're coming home and all that's going through your head is, am I going to make my kids sick? Am I going to make my spouse sick? Am I going to make my parents sick? Who, heaven forbid, I infect somebody else unknowingly because I wouldn't be able to live with myself. It's just that level of fear and uncertainty that was unlike anything else. And all of a sudden, people were very appreciative. And I personally like to joke that working in the ER is like being in an abusive relationship with the public, where we are the victims. Because the public, gets away with quite a bit, where if you pulled that with a McDonald's employee, you probably get arrested. But here I'm being pulled into the office to say, like, what could I have done better to avoid getting hit, in these types of situations. So just the complete turn on its head of people being exceedingly thankful, and food and banging the pots and pans and all these things. It was very disconcerting because I was like, I don't know what to do with this. Like, if you're yelling, I know how to deal with that. That's easy. You being thankful and really super nice and kind and thank you. I don't know what to do with that.
It's okay. It didn't last long.
No, it didn't. Right? You're like, oh, we're back to the normal. Thank goodness. All right, we can do that.
Sad yet true.
Yeah.
Jen, we're going to take a brief water break. Audience, thank you for listening to the first part of our conversation with Jenn Johnson and all things emergency nursing and rural health. And we have so much more to cover in part 2. If you're enjoying this conversation and all our conversations on the voices of healthcare equity, please go to our website, https://haew.org, to learn more, learn how to partner with us, be a guest, or donate.